So an interesting case that a lot of us get is someone who comes in with forgotten double J stents. They're markedly encrusted. And you say, oh my goodness, how are we going to deal with these encrusted double J stents? What are the appropriate expectations for the patient? Or do you have the appropriate equipment for the patient and for the ancillary staff? Is the ancillary staff a team that's working with you all the time so that you can do this in a productive fashion? And so the first thing from my perspective is when you see these double J stents that are encrusted and you have large volume stones proximally in the kidney, is to first start in a retrograde fashion to take care of most of the stones in the bladder, the distal ureter, and go up as high as you can up the ureter to be able to remove as much of the stone and possibly even cut the double J stent if need be, so that when you subsequently go in percutaneously, you could take the stones from the kidney and the proximal encrusted double J stents out. I'll probably typically use a cystoscope, and I'll use a laser or an electrohydraulic probe to get rid of as many of the stones, or all the stones from the bladder, so that then I can put up a semi-rigid ureteroscope from the ureter orifice up as far as I can. That allows me to use a laser, baskets, and a variety of other equipment to remove as much of the stone from the distal ureter as I can. These can be very tedious. You also have to do appropriate antibiotics because a lot of these have obstructed systems proximal to these encrusted double J stents. Then it would be nice to use a flexible ureteroscope. Typically, you can't use a ureteral access sheath because there's so much in the ureter to begin with. And so we'll then go up with a flexible ureteroscope, like the LithoVue, which is the disposable ureteroscope, to use a laser to dust the stone so you don't have to go in and out as many times. However, even if you try to dust the stone, there will be fragments, and using a basket to be able to pull these stones out can be tedious, but it's important to be able to get as much of the stone as you can distally before you go in an antegrade fashion. When you go percutaneously, to be able to do either antegrade stone removal and antegrade ureteroscopy, classically we've taught to do these in an upper pole puncture, which is fine. You don't necessarily need to do an upper pole puncture. You could do a middle pole puncture also, or even a lower pole puncture with the flexible ureteroscopes. Going from the upper pole, in my mind, is advantageous. One, to teach residents how to do an upper pole puncture is pretty straightforward. You take the needle and you go straight up and down onto one of the calyces, the superior calyces. The upper pole calyces are typically medial and lateral, in contrast to the lower pole calyces, which are anterior and posterior. So it doesn't really matter which calyx you actually hit on the upper pole. So then you put your needle straight down onto a calyx. You move your C-arm away from you, and then that'll tell you the depth of the needle that you need to advance into the calyx. Then you put your wire in, use a dilating system of your choice, and once you have a sheath into the collecting system, you either can place a nephroscope and or a flexible ureteroscope to go on down to be able to pull out that encrusted double J stent. As in everything in endourology, you do not want to force anything. If it doesn't want to come, stop, and then go through a laser or other mechanism to break up the stone so you can pull out the double J stent, which is what your initial primary goal is. Sometimes you need to cut the double J stent just to get it out of the way, and you can use a laser to be able to do that process. I will leave a nephrostomy tube after these procedures. It does a couple of things. One, it drains the kidney because these have been obstructed for a long time. And two, it gives you sort of a leash on the patient, meaning that if the patient has to go home, they're not going to be forgotten because this tube's going to be coming out their back. And on the whole, not 100%, on the whole, they will come back. You could do a nephrostogram and then take that nephrostomy tube out. In contrast to putting a new double J stent in, which may get forgotten again, and then you're back to square one. These types of patients are typically not the most reliable in terms of follow-up. Treating forgotten encrusted double J stents is a difficult process. You need to inform the patient they probably require multiple procedures requiring a semi-rigid ureteroscope, flexible scopes, and ultimately may require a percutaneous antegrade extraction. I think informing the patient and family of the complexity of it and ensuring that it doesn't happen again are the critical issues in managing these patients with forgotten encrusted double J stents.